Hi, this is Salman Alana and Manos Brilakis, and this is case 218 for the Manual of CTO Interventions, describing a case in which the retrograde microcatheter became entrapped. This is an overview of the complications of PCI and CTO PCI, and there are three major things that can happen in the coronary artery: either close it, or perforate it, or have equipment loss or entrap in the coronary artery, and this case pertains to this particular issue. The patient was a gentleman who had ischemic cardiomyopathy. He had an non-ST elevation myocardial infarction with refractory angina despite optimal medical therapy. He did have an ejection fraction of 19%. He did have an RCA CTO with viable RCA territory, and he had an unsuccessful attempt for recanalizing the right coronary at an outside hospital and was referred to us for recanalizing the right coronary artery. Because of the low ejection fraction, we decided to use hemodynamic support, even though his LVDB was okay. And then because the patient was moving constantly on the table, he had restless leg syndrome, he was electively intubated. These are the dual injections. We have an AL1 guide into the right coronary artery and an EBU 375 into the left. And we see we have a CTO of the mid-right coronary artery. There is a blunt proximal cap. There is a long occlusion length. Actually, we do not have a good visualization of the PDA of the distal RCA. This could be seen in previous angiogram, but not in our setup film. So what we have is a patient with a CTO of the proximal to mid RCA. This is a blunt stump, length about 40 to 50 millimeters, not visualizing distal vessel, and there are some septal collaterals. Hence our plan, given the poor visualization of the distal vessel, to go with a primary retrograde approach. If that failed, then try Antegrade. We inserted a Caravel microcatheter to the first septal and did attempts for surfing. It didn't work initially with Sion Black and SUO3, but eventually we were able to cross with the Filter XTR. However, we had difficulty advancing the Caravel microcatheter. There was a previous stent into the LAD, and the wire position was lost. We then advanced a FineCross and a Sion Black, and we were once again successful in going into the PDA. But advancing the FineCross was challenging. Eventually, we were successful, and we performed an injection through the FineCross, demonstrating the presence of the distal right coronary artery. However, the FineCross could not be advanced any further. So we advanced the retrograde guidewire, and then we had difficulty advancing it any further, so we decided to go Antegrade. We had some difficulty wiring through the proximal right coronary artery, but then we're able to advance the guide wire, and actually we do have the Antegrade and the retrograde guide wires to be very close with each other. Always orthogonal projections to confirm, and sure enough, the two wires are next to each other and dancing together. So we inserted a guide extension to the mid-RCA, and then we were able to advance the retrograde guide wire. You can see the FineCross had moved a little bit further down. The retrograde guide wire was successfully advanced into the Antegrade guide catheter. So this was a guide extension assisted reverse cart. But the problem started then because we were unable, despite trapping the retrograde guide wire into the Antegrade guide extension, we were unable to advance the retrograde FineCross. And when we tried to pull it back and replace it, we were unable to also pull it back. So we're now entrapped. We have a FineCross retrograde microcatheter that is entrapped going through the previously placed stent on the LAD. So what to do? Several different things. We tried to advance a wire and did ballooning. We then did circumcision of the back end of the FineCross and then advanced the guide extension as well as a 4 French diagnostic catheter that we brought, as you can see here, essentially all the way to the point where the FineCross goes through the struts of the LAD stent. Despite that, the FineCross could not be moved. You can see how the proximal end of the FineCross looked like after the circumcision. Essentially, we cut it and remove the back end, so now we can load the guide extensions and other equipment over the same guide wire. Once again, we advanced another wire, did balloon inflation next to the entrapped FineCross with a 1.2 millimeter balloon. Unfortunately, that was not enough to release the FineCross. And in the process, while we're trying to pull the FineCross back, the patient had bradycardia and hypotension, had a brief PA arrest, got CPR for a few seconds, got atropine and epinephrine, and we actually even put in a temporary pacer, but the patient subsequently stabilized, and although we had initial plans to put him on ECMO, because of the subsequent stabilization, we actually held off ECMO. However, his PA pressure had significantly increased. So what to do? We ended up doing the T-pin technique, which was facilitated by inflating an Antegrade balloon. So we advanced the tip of an Antegrade FineCross microcatheter over the tip of the retrograde guidewire, and then advanced the FineCross Antegradely. And here is the FineCross going Antegradely all the way to distal RCA. This is the entrapped retrograde FineCross. So the plan was to potentially advance the retrograde guidewire. Maybe you can balloon into the septum and have the microcatheter released, but we were unable to do so. We also advanced a 2.0 millimeter balloon, but we were not able to do so as well. After that, we advanced again different balloons through the LAD stent into the septal and did balloon dilatation, but once again, this did not work. And this was now several hours. We've spent several hours that we've spent inside the cath lab, and we're getting quite desperate at this point, because we knew that if the patient went to surgery and the surgeons were there and they were willing to take the patient, but it would have been very challenging to remove the equipment, and given the patient's low ejection fraction, it is quite likely that he would not have survived the cardiac surgery. So there's always the saying, if you have trouble, phone a friend, and we did call Tony DeMartini, who was very kind to provide a suggestion of maybe getting the guide extension inch-warmed over the secondary guide wire and the entrapped microcatheter, and then maybe that would go deeper, and that would allow us to actually remove the entrapped FineCross, and actually it worked. We advanced the guide extension over both wires, both the entrapped FineCross and the wire, and also the body wire which he had used into the septal, and then to our big relief, things came out. And this is how the FineCross looks like. We can see that essentially the polymer coating of the catheter has almost completely been stripped off. There has been a significant damage. You can see even the coils inside the microcatheter, and that is why we had the difficulty retrieving it. There was some damage of the microcatheter, and that was essentially rubbing against the stent struts of the LAD stent. Fortunately, we still had access to the vessel through the wire we had advanced previously. So we deployed 2 drug-eluting stents, and that restored flow into the right coronary artery. And the patient remained stable. We kept the Impella CP overnight in the unit, and he did have a prolonged hospital stay, but eventually he was able to be discharged. So there are several lessons from this case. The first one is that if you have stents in the donor vessel and you plan to go through those stents into a collateral for the retrograde approach, it is very important to dilate those stent struts, because if not, the chance of entrapping the microcatheter goes up. The second is what to do when the microcatheter will not follow the retrograde wire into the Antegrade guide or Antegrade guide extension. It was the case in our patient. One potential option is to actually leave the retrograde guide wire there and come with an Antegrade microcatheter and do the so-called T-pin technique, advance the Antegrade microcatheter into the retrograde guide wire. In this case, we did use a small 2.0 millimeter balloon to facilitate this meeting of the retrograde wire and the Antegrade microcatheter, but it was eventually successful. And finally, when things are happening, so in this case, you had the FineCross being entrapped. And we tried different things. We tried to balloon next to it. We tried guide extension. We tried to go Antegrade and retrograde and balloon distally, but this did not work. But eventually calling a friend, calling Tony DeMartini, was critical. He gave us the suggestion of inch-warming the guide extension through both the guidewire as well as the entrapped FineCross. And this is what finally did the trick and helped us remove the entrapped FineCross. Thank you.